What's up everyone, this is Bo from Buzzwords Med. Today we have a fantastic quick video regarding dermatology for the STEP exams. I'm going to tailor a little bit more to Step 2, but still very pertinent for Step 1 as well as for Step 3. So let's get to it. So, you get one of these two pictures on your test. What do you immediately think about? That's right, contact dermatitis. So, contact derm, something that will appear quite commonly. You can see that it's in the fashion of the ring, or it could be on someone's abdomen. If you see that, likely secondary to a belt buckle, nickel allergy, for example. Now, the question they're going to ask you, because they're going to know that you know that this is contact dermatitis, and they're going to ask you a follow-up question one level deeper, and they're going to say, what type of hypersensitivity reaction is this? In which case you would answer, right, type 4 hypersensitivity, T-cell mediated. So just a couple key facts for that. You treat it like anything else. It will go away, but topical steroids will do the trick and relieve symptoms for the time being. But that person forever will have that allergy and will need to know that moving forward. All right, our second question, or second image, excuse me. You have a kiddo with that, and you have a gentleman with what looks like a bunch of flaking around his mouth, probably his nose area. If you look at his forehead, probably there as well. And then the kiddo, it's something called cradle cap, if that gives you a hint at all. So what do both these people have? That's right, seborrheic dermatitis. So largely, sebderm is thought to be a fungal infection. Often it starts manifesting around puberty. There's a certain demographic that's just appears to get sebderm a little bit more commonly. There are two pathologies that we should know about that are related to seborrheic dermatitis. So if someone, for example, came to your derm clinic or just to your PCP clinic or was on the Step 2 exam and all of a sudden they had an outbreak of sebderm, they were just flaking everywhere. There are two things you need to consider. One, HIV. Two, Parkinson's. For whatever reason, I'm sure there's literature about it, but HIV makes more sense intuitively. Maybe this fungal infection is you're able to kind of keep it down with a good immune response, but the second that's gone, maybe it starts just going crazy. And then Parkinson's, I'm not sure whether it's an inability to care for yourself or if there's some other underlying pathogenesis. But regardless, so if you see a cradle cap on a newborn, think sebderm. If you see any of this flaking around the T-zone, think sebderm. Treatment is both fight the inflammation with some topical steroids. You can use a shampoo, like an antifungal shampoo, like you would for your tinea versicolor, and then you can also use topical antifungals, let's say if you're getting around the face or other hard-to-reach areas. So a combination of antifungal and anti-inflammatories for seborrheic dermatitis. Now, what's this? Some classic pictures. So this is psoriasis. You always want to remember psoriasis or those plaques. They have that silvery scale, really bothersome condition, itchy at times. So treatment is, I think, a little beyond the step. Treatment is a little beyond the scope of most step exams. I would say just know the basics that if you have isolated areas, isolated plaques, you can try topical or intralesional steroids. But beyond that, you're getting into biologics, among other things, methotrexate, tough stuff like that. So I would just know what psoriasis looks like and then know kind of the basic treatment modalities. I put the picture of the nails down there because there are some interesting nail findings that you can find in psoriasis, such as pitting within the nails, onycholysis, oil spots sometimes, some overlap with dermatomyositis perhaps where you have those dirty kind of nails. But this is just a good image to kind of put in your head if you see someone with psoriasis or if you see a passage where they have a derm condition and they only show you the nails. It's one to remember for sure. This next one, what do you guys think about this? A targetoid lesion, erythematous on the ends, perhaps one would say even a little dusky in the center. Right, this is erythema multiforme. There are countless etiologies. The most common ones and the ones that you should know for at least for the USMLE exams include herpes, HSV1. They include mycoplasma. If you're going to think about a bacterial infection and EM, you're going to think mycoplasma. And then you're also going to just think drug reaction. So I think it's herpes, drugs, mycoplasma in that order. And so otherwise, it will resolve on its own. But there are some people that get EM and it transitions to something more dangerous. And this is it. What would this be? Right. This is SJS, Stevens-Johnson syndrome, or TEN, toxic epidermonecrolysis, depending on the body surface area. The cutoff point is what? Right, around 30%. So if you see someone with this, basically you treat them as what? Right, you treat them as a burn patient. That was kind of a read my mind question. So these guys that are super sick, they actually go to the burn units at most hospitals because they may be treated with some pretty aggressive management. If the inciting factor is still ongoing, make sure you stop it. Otherwise, it's symptomatic treatment until it resolves. All right. This next one, it was actually on one of our infectious disease videos. What is this? That's right, erythema nodosum. So painful, tender erythematous nodules on the shins typically, can be in other areas, but this is classic extremities. When you see this, you think about multiple things again. Just like EM, there's countless things, but for the board exam, there are a few key things that you need to think about. One is infection. So in the infectious disease video, we talked about it in the setting of coccidioides, so fungal infection. You think about it in the setting of strep, in the setting of tuberculosis. And then granulomatous disease, you need to think about those. So sarcoidosis can lead to this. Sarcoid can lead to anything really. It's a great mimicker. So, but one key thing is erythema nodosum. So think about sarcoid with this as well, and then also medications, countless medications, sulfa, antibiotics, among other things. So a lot of etiologies. Just know that this is what erythema nodosum looks like. Treatment is basically symptomatic until you can figure out what the underlying cause is. And then finally, this is the last part of this video. We have two lesions up here, kind of sister lesions. Which one is which? We have a bullous pemphigoid and a pemphigus vulgaris. So, pretty classic pictures. The one on the right hand with the actual bulla intact is bullous pemphigoid. Typically not as dangerous. The lesion is actually at the basement membrane, so it's the epidermis is strong enough to stay intact, and therefore the bullae stay intact. Versus pemphigus vulgaris, where the lesions are actually intraepidermal. They're actually between the keratinocytes. So that's where the sloughing occurs. You can get the Nikolevsky skin, where you just kind of rub the skin and it will start just sloughing off. Something similar you see in toxic shock, but you can see that in pemphigus vulgaris, so that's a key differentiator. There is a difference in age as well. Typically, pemphigus vulgaris, they say the average age is between 40 to 60 versus bullous pemphigoid, greater than 60 years old, so another differentiator if you're not too sure. And then finally, the treatment is, since this is an autoimmune disease, the treatment ultimately is to tamper the immune system, so things like steroids or rituximab, or among other things. So just know that probably steroids would be the right answer in the scope of a USMLE exam. So bullous pemphigoid, pemphigus vulgaris. Very high yield. Very rare in practice, but very high yield for these USMLE exams. Alright guys, I hope you guys enjoyed this quick video regarding some of the most high yield derm conditions for the USMLE exams. Make sure to smash that like button if you found this useful so others like you can find our videos. And if you want more practice exams, if you want to see where our podcast is, and if there's anything else that we might be able to help you resource-wise, check out our website, buzzwordsmed.com. Alright guys, reach out if you have any questions. Until next time, take care.